welcome everybody to this evening's meeting. And I'd just like to highlight how I think we would like to do this. I'll introduce the three main speakers who are each going to give a 2-minute breakdown as to their views in respect to social care. We're then going to try and do a moderated panel discussion for about 20 minutes, which will take us to about 6:35. And then after that, we'll do a live questions and answers. But please do be patient, as you know, it's very difficult making sure you've seen all of the hands which have come up or gone down, etc. And if I do miss anybody out, I sincerely do apologize. So very briefly on myself, I'm basically a clinician scientist who got dragged into the dark arts of management. I think my brother would probably say I never understood the management and still don't. But this is a massive issue which we're facing as a country at the moment. Ian is going to start with his 2-minute oration, as I can put it that way. Ian is currently chair of the Surrey Heartland Integrated Care System, so right at the cutting edge of these new changes. He previously has a history of being chair at King's College, and before that he was non-executive director, a Triatlantic partner of the the Equity Group. And before that was chair of Four Seasons Healthcare, which of course is the biggest care home operator. So he has a very broad knowledge. And before that was head of General Healthcare Group, so the major private sector parties. So Ian is going to be the first of our speakers. Our second speaker is Jane. There you are. Nice to see you again. Jane, I think you started your life in the commercial sector at ICI, AstraZeneca and Syngenta, where I think you ended up as global head of bioscience research. And you seem to have had something of a transformation since then, setting up your own business, and now has substantial links within the link between business, public health, lifestyle, and very much the issues which we're going to get into this evening. And last but by no means least is Matthew, who I'm not sure you need much of an introduction, Matthew, but of course you are currently Chief Executive of the NHS Confederation, having previously been Chief Exec of the RSA. And you were Principal Advisor to Tony Blair in respect to political strategy when he was Prime Minister. So we have a very substantial triplicate, if I can say, who are going to lead it through the moderated discussions, the meeting this evening. So without any further ado, Ian, can I turn to you for your short talk?
Sure, okay, thanks, Stephen. So I'll make 5 points as introduction. Firstly, social care is an increasingly vital part of the patient pathway. You know, given the advances in biomedical science and practice, people living longer, but with chronic diseases, and also our changed attitudes on mental health, particularly closing the asylums where 150,000 people were incarcerated as late as the 1960s. Social care is an increasingly vital part of the patient pathway. As a result, I think it needs to be fully integrated around the patient. To take a couple of examples, a frail elderly patient with cancer will die of malnutrition if they are not helped to feed themselves just as much as that person would die of cancer. We've also found that cancer survival rates decline substantially if patients become more frail and weak and are excluded from the social care system. So this isn't a nice to have, it isn't something completely separate. It's very central to the patient experience. As a result of that, I think we need to merge the workforces of health and social care. There are cultural differences between local authority and NHS, but I think people make far too much of those differences. Those differences are a nonsense to patients if we take a patient perspective. And I think the task of competent management is to stay focused on patients, as I say, who do not understand or want the separation of those two services, and competent management that recognizes and manages the cultural differences and puts those at the service of patients. I think that inclusiveness also needs to include the charity and third sector, which has too often been excluded, especially from NHS service. As a consequence, I think we also need to merge and increase the funding into an integrated hypothecated tax, obviously with adjustments to keep it growing and to keep it fair, and allocate those funds wholesale to the new integrated care system instead of the drip-fed funding that is so suboptimal at the moment. And I think this is the moment. I think the integrated care systems are the right organizing principle. And I think they can make a big difference in integrating health and social care in the interest of patients.
Thank you very much, Ian. Jane, could we turn to you?
Thank you. Yes. I'm Jane Townsend, Chief Executive of the Home Care Association. So we represent and support providers of care in people's own homes. And I just wanted to really start by making the point that the little dot at the bottom of this pyramid are hospital beds, about 100,000 hospital beds and about 400,000 care home beds. And then everything else in the pyramid is all people living in their own homes, either being supported by informal carers or by paid for carers. So probably about 15 million people altogether needing and receiving care in their own home. But the way that we spend our money is by pouring all of it into the NHS. The amount that gets spent on home care is only 4% of the total NHS budget. And we've got a massive issue with, all of the funds being poured into hospitals instead of supporting people to live well in the community. And what we really need to do is invest in home-based and community support to help keep people out of more expensive settings. I'm not going to talk about organisation because I find that a bit dull. I'm going to talk about data. And this is where I'm trying to sort of show the art of the possible here. So this is a study, it's a proof of concept study from France where they had 300 people over 75 and they had home care workers going in to see them. The home care workers didn't know anything about their medical conditions. They just made records like they normally do about 27 different observations. And that would be things like, has the person got themselves out of bed? Have they been able to make a meal for themselves? On as far as medical conditions, it would just be sort of the person seems feverish, the person's legs are swollen, sort of like that, no actual measurements of anything. They may record behavioural changes, so the person has got agitated, the person has refused help with grooming, those kind of things. And then also some observations about communication. So they've met their family this week, they seem a bit low in mood and so on. So there were 27 different things. And then they tracked these people over a year and they observed the people that ended up in A&E. And they took all of these data points and used sort of clever data science and algorithms to see what they could model. And the short version is that they were able to predict with 70% accuracy admission to A&E 2 weeks in advance, just from taking these data points that were quite observational and analysing them. And what I think this points to is the possibility of using data gathered from lots of different sources. So home care, if you were to add in remote health monitoring too, we could start to shift that curve. And some of the 27 items that they noticed had a disproportionate impact on likelihood of somebody ending up in hospital. And some of the most powerful ones were ability to move around in your home, ability to prepare your food. So as Ian said earlier, sometimes just not getting proper nutrition is enough to determine an outcome. And then things about social condition and communication and mood. So this is my last picture that actually people receiving care at home, if we keep people connected to their communities, keep them active and engaged, enhance their well-being, ensuring they've got that choice control and they're kept safe, that helps to give peace of mind and practical support for their family and informal carers. That improves health outcomes for both them and the people receiving care. In turn, that reduces pressure on the NHS, reduces costs to the system, helps to keep people in work, both people receiving care and their family carers. Obviously, employment and professional career opportunities for the workforce. And as Ian said, if we look at the workforce in a more holistic way, we can expand those opportunities and ultimately sort of contributing to GDP. So my argument really is that data is the key to this rather than organisational form. And there's lots of different ways that we can pull that together.
Thank you very much, Jane. Matthew, can we turn to you?
Thank you. I think it's important to say at the outset that the state of social care in England is a scandal. And it's something that we ought to be ashamed of as a country in relation to the paucity of provision that we make to some of the most vulnerable people in society. And we tend always, don't we, to assume that people who need social care are very elderly people, but of course a very high proportion of people who need social care and rely on social care are of working age, and they are being very often denied the opportunities to fully participate in society as a consequence of the fragmented nature of social care delivery. I also think that sadly we have missed the opportunity, or we seem to miss the opportunity, to address the fundamental problem of capacity. So the government social care reforms, whatever one thinks of them in relation to the degree to which they protect the assets of better off people, they do not address the fundamental problem of capacity, a problem which is worsening every day. But not only is the state of social care ethically unacceptable, but it's counterproductive in a number of ways, which Jane has hinted at. So firstly and most obviously in the NHS, that many of the problems we have currently got as I speak in terms of the front door and the back door of hospitals is to do with weaknesses in social care provision, because it's people going to A&E because they're not getting the social care they need, and it's people, thousands of people who cannot get out of hospital because of the lack of social care provision. Again, a problem that is getting worse and is being exacerbated right now by wage inflation in the sectors that compete with the lowest paid social care workers. Secondly, it's counterproductive because we're failing to enable people to remain independent. And if we provided better social care to people who were less dependent and earlier, we would enable them to enhance their independent, stay independent for longer. And thirdly, and connectedly, absolutely building on Jane's point about the incredible scale of voluntary commitment here, that we are not empowering families and communities in the way in which we provide social care. One of my favorite organizations, Berkzorg in the Netherlands, which is a domiciliary health organization, when it talks about what its staff do, it draws a diagram with concentric circles, the individual, the family, the community, and then the social care, the healthcare provider, and it sees its role as empowering each of those circles rather than pushing them out of the way. Final point, 2 points, is that Sunday was the 20th anniversary of the Wanders report. And I believe we need to return to the fundamental insight of the Wanders reports. And of course, it is a report on social care as one as well on health. And that is that we have to invest in the short and medium term. But if we do so, and we do so in the right way, and this is Jane's point, we can reduce costs in the long term. So we needn't be pessimistic about health and social care consuming an ever greater proportion of GDP in the medium term, as long as we invest now in the ways in which we need to invest and we have the right policy framework. So organizationally, we do need better integration between primary care, community trusts, adult social care, non-acute mental health at place level. I'm agnostic about who does that. I think probably local government needs to be the accountable body, but I think it's about allowing local systems to determine how best they bring things together, as long as they are brought together. And if we do that, we can make a real difference, and we can innovate, and we can actually solve a lot of these problems, but we're going to have to put sufficient money into the baseline resource if we're going to be able to do any of this.
Thank you very much, Matthew. Perhaps I could start the debate off by, I think you've all given a very strong and powerful argument for the woes, if you like, of social care. And I think, Matthew, you were alluding to sort of what needs to be done in social care. But there's another recurring theme, is this link between social and healthcare. Can I ask all three of you, from a political perspective, is this indeed possible, or is it better to put the two of them together, or is it better to keep them and see politically how far you can go one side or the other? It seems to me that's the first question, which I think you've all three alluded to, but what's your solution now? Should they be lumped together, or should they be addressed separately? Perhaps Ian first. You're on mute, Ian. You're on mute.
I think lumped together is not really the way we should do it. you know, in my job at the moment, it is about delivery. You know, it is about marshalling those services for, in our case, the 1.2 million people in Surrey. And you know, as I said earlier, for the patient or the citizen or the resident, you know, they don't really recognise this historical accident that occurred in 1948 to separate health and social care. And in many ways, it didn't matter in 1948 because people died mostly at the age of 60 and within 6 months of their terminal illness. That is a completely different epidemiology of disease than we have now, but our system hasn't adapted. So I come at this from the point of the patient, point of view of the patient, Mrs. Smith, Mrs. Jones. What is the package of care that we need to put around that patient and citizen to keep them safe in the first place, so that they do not deteriorate and need to go to busy and often dangerous hospitals? I want to put integrated care around that with a care coordinator, preferably a clinician, managing full cycles of care so that the pathway for the patient is seamless. And the stitching all of that together is something that NHS, local authority, and third sector and carers do, if you like, behind the scenes, that it is seamless and invisible to the patient or the citizen.
Yeah, Jane, how do you see it? You made a very strong point about the, you know, ED attendances and social well-being in a sense. How will you bring them together?
Well, I think one of the, like I said, a lot of the money's gone to the NHS, and we've made the mistake, and I've said this before, of thinking that health has got something to do with healthcare, when it's actually really a lot to do with the social determinants of health. And some of the most powerful predictors of people's likelihood of ending up in A&E is things like how mobile are they? Are they getting out and about and seeing people? Now, none of that is sexy medicine. That's really basics, you know, things to help people stay connected to their communities. And this is where, you know, the third sector also comes in. But a lot of the support of that lower level has all been stripped out because, as Matthew said, the budgets have been cut and cut and cut. What I feel quite encouraged about really is that the NHS has recognised quite a lot of this, and they're busy putting proposals together for what they call anticipatory care, which we would probably call social care with some healthcare thrown in. But the idea is, again, to use data, trawling the NHS data sets to look for people that meet certain criteria. So people that have got 2 or more long-term conditions as measured by, say, a recognised frailty index, maybe other social factors like they're on their own or whatever. And that cohort of people then become, they're assessed and then come under the care of a multidisciplinary team. And that multidisciplinary team can be drawn from, you know, across different organizations, because I think a lot of people think the NHS is a single entity. It really isn't. You know, you've got GPs that aren't even, you know, technically employees of the NHS. You've got community pharmacists. You've then got, you know, district nurses and allied health professionals, and you've got the acute hospital. So in itself, it's a load of different organizations. So I think the idea that we can create some great big organizational entity that's going to solve this, I think, is misguided. I think we have to get that strong leadership to pull those multidisciplinary teams together on the ground and use the data to help us do that. And so with anticipatory care, the NHS is talking about a whole range of different potential interventions, from at one end helping people manage themselves, through to things like maintaining mobility, helping people with nutrition, through to remote health monitoring and more, you know, perhaps community geriatrics as well. So I feel quite encouraged that that thinking is there. And I think that's how we have to make it work on the ground. People will pull together if they're focused on the people who need support.
Yeah. Matthew, can I ask you the obvious sort of political question that the minute you put health and social care together, I don't know a single politician in the country who doesn't say spend more money on health. When it comes to spend more money on social care, I don't know if I know any politicians who are keen to do that. How do you handle that political imbalance between clear public support on one hand and suspicion on the other that you've highlighted in your introduction?
Well, I mean, the first thing to say is I think there are quite a lot of politicians who say that the health service doesn't need more money, because we had in a great fanfare last autumn the announcement of the levy and the 4.1% increase in NHS funding. Unfortunately, due to what's happened to the cost of living, that 4.1% is now more like 2.6%. And so that's also on top of doubling the efficiency target and trying to deal with the backlog. So as Ian will know, this absolutely does not feel like a time of plenty for the health service, although somehow the government has managed to create the impression that is what's happening. I think that every health leader I know, and Ian exemplifies this, understands the interrelationship between health and social care. And indeed, a lot of health leaders, in the face of the fragmentation of social care, have had to think themselves about what they can do to actually support social care provision in order that it's able to do its job. I think that I completely agree with Jane, of course, that we need a wider lens on the circumstances which lead to different outcomes for people. One of the really important insights I think to have here is the relationship between acuity and quality of life is attenuated. There are people who have the right kind of support, whether it's housing, employment, friendship, community, with quite severe conditions who can have a good quality of life. And there are people with relatively moderate conditions who have a terrible quality of life because they don't have those support mechanisms, many of which are not to do with the health service. So the opportunity, it seems to me, of system and place working is, on the one hand, the achievement of better integration and collaboration, and on the other, widening the lens of health policy. So it isn't just about what the health service does, and it isn't just about what the health service and social care does, but is about the wider factors that Jane described. Yeah. And if I can just say something about ICSs, because that's not the focus, but we, the Confederation, are proud to be the membership organisation for ICSs. I think the critical thing for ICSs is that they are not empires or layers, which is often how they're talked about, a new layer within the health service, a new kind of organizational bureaucratic empire. They need to be seen as facilitators, as enablers. So not adding to the complexity, but actually making that complexity more manageable. And indeed, I've often thought that one of the problems with public service collaboration, and indeed with place work, is that we invest in cogs, we don't invest in oil. And so we need to see ICSs not as a new cog, but actually their fundamental role is precisely about connecting up different agencies around a kind of shared vision of care and a shared vision of how it is we improve health outcomes. So I think if ICSs understand that role, and critically, and this is a different subject, if NHS England and regions allow ICSs to be locally focused enabling bodies rather than transmission mechanisms for national instructions, then I think we have a chance to make real progress here. But I will still reiterate what I said at the beginning. That progress has to be premised upon a greater investment in the kind of baseline.
Yeah. Ian, can I ask you're taking that sort of argument, or not argument, but discussion on, what chance do you think you've got of preventing NHS Centre, for want of a better word, dictating, dare I say, as I suspect they've done most of the time, dictating what they want to happen? How much flexibility and freedom do you think will be allowed to go into this more corporate facilitating mechanism? Because we all know that once the minister's under pressure because some health statistic is going wrong, cancer rates, death, all the usual stuff, the knee-jerk response is pretty quick from NHS Centre, which is you will all do this now. Do you get a feel that there's a change in that mentality?
That's why I subscribe to NHS Confed, Matthew, so that people as dexterous politically as Matthew will make that case at the politicians and at NHSE. I think it's a big problem. I mean, I think it's a clear temptation for the centre, NHSE and I, to grab the wheel, especially with politicians who are very concerned about, at the moment, as we know, access to GPs and waiting lists. So I think we've got to be sympathetic to them and deliver on that, frankly. I think we have got to improve access to GPs and reduce waiting lists. But I think we've got to say, we're on that agenda. We're going to do that. It's very, very important to people's lives. But also then say, if we are really going to create a system that is focused around patient pathways, about citizen well-being, then please let us get on with it. Not sort of, here's, in our case, what, £3.5 billion and come back in 10 years and see how you've done. Of course, we need to have outcome measurements. We need to make sure we're spending that money in the best interests of both patients and taxpayers. But I think it needs to have a much lighter touch than currently.
Mm. Jane, taking the sort of same question, but from the other side, how can social care, I don't really mean up its game, as it were, but is there some mechanism in which the clear link between well-being, Michael Marmot's stuff, and as you say, that your data on ED, how might social care begin to try and transition into, for want of a better word, a more acceptable face to the general public? I mean, Matthew, I think you made the point about everybody thinks it's all about old people, but I think it's the case that at least half of all adult social care money is spent on people of working age. So it's not, those of us who are pushing the ears on a bit. How would you begin to try and do that, Jane? Because you're very much involved in how you get this personable thing into public policy.
Yeah, I mean, I guess we probably sort of have to rebrand ourselves as social prescribing or anticipatory care or something, and kind of, this is where I'm seeing some optimism that, the NHS itself is talking in those terms. And, back to NHS England, they've set sort of, sort of contract terms that I think Matthew will know better than me, but I think every trust has got to have an anticipatory care plan, by next year or something. And okay, that's just one type of service, but I think it's getting that recognition that all of those other things, like keeping people mobile, keeping people fed and hydrated, is just as important as having the latest fancy drug, and I do think maybe with the politicians, one thing to push on is that, certainly they're very keen on technological innovation, and there's definitely opportunities there, but I don't think that we can leverage the value of that unless we change the way we do things a bit. So we've talked previously in some of these calls about GPs being the gatekeepers to everything. And at the moment, if you do some of our members have done some remote health monitoring in collaboration with NHS colleagues, and then you go along to the GP with all your data on Betty's blood pressure, and the GP says, I just haven't got time to look at your data on Betty's blood pressure, don't tell me about it because I'm going to have to do something. So it's not because they don't care, and they're just really busy, but it doesn't really make sense to put funnel everything through them. Maybe there needs to be some different types of services in the primary care networks, to help us figure out what outcomes to measure and to gather the data together, and then to push alerts out to home care providers. Like we've seen this change in Mr. Jones. We think that you need to go and put a bit more effort in there or something, so that it's a lot more dynamic. The way that home care is commissioned and purchased is it's focused on process. You will go for this many minutes and you will do this. It's not really thinking, how can we be flexible? How can we give autonomy? Somebody mentioned Buurtzorg. The reason that works so well is because those nurses leading it have autonomy on the ground. They're going in and seeing people, they're seeing what needs to be changed in the moment. That's where we need to get to. But I think the answer is having these multidisciplinary teams, and you could have, say, a district nurse, being supported with some home care workers and being able to pull in, the GP as required, allied health professionals as required. It takes some sophisticated leadership, but it is possible because I've seen it happen. I've seen it work.
Thank you, Jane. I mean, it's a thing I've made a long point about. Having been a Dean of Medicine for 10 years, I'm afraid have to take some blame. I'm just not sure the general practice model fits anymore. Matthew, and you both mentioned the Dutch model. Dutch have 24 hours a day, 7 days a week primary healthcare. It's not done by general practitioners, it's done by primary healthcare organizations, exactly as we've discussed. And that, of course, is a different way in which you can bring in a whole host of different players. Although I have to say the Dutch are the only ones in Europe who keep the GP as a gatekeeper. No other country has the GP as a gatekeeper. But Matthew, how can we begin to pull those together? Because we're often accused of whinging and complaining, and we're extremely good at being British. We're extremely good at identifying, or at least some are our weaknesses. how politically can you begin to get a sort of cross-party movement, which one just wonders if that's emerging a little bit at the moment, that the old left-right sort of dichotomy isn't quite as rigid, I'd suspect, as it was in the past. How might we begin to politically move this in a more, group fashion?
Yeah, as I said earlier, I think it's really interesting that it's 20 years since Wanless published his review. He was commissioned at a time that feels quite like today. He was commissioned at a time when the health service was under enormous strain. There had been a set of scandals about the quality of provision. And there was quite a big hubbub about the fact that the NHS was simply unsustainable in terms of its kind of core principles. And Wanless was invited in to look at this. And I think that his core argument is actually more true today than it was when he published, partly because of innovations in data and digital and medtech, which are potential game changers. So I think politically the argument we need to have and to try to win, which is doesn't I think need to be ideological. I think there are people who are ideological on either extreme of this debate. There are some people who simply loathe the NHS and everything that it stands for, and there are others who find any idea of reform threatening. But I think we have to win the argument, which is that actually if you put together the various ways in which you could do things better, it is absolutely possible to envisage a point in, I don't know, 10 years where health and care starts to decline as a proportion of GDP, but you won't get there unless you undertake the correct investment. I mean, one of the most startling statistics about our system is the amount of capital that is invested per healthcare worker. I mean, we are completely off the scale in terms of capital investment. When I say off the scale, I mean the bottom of the scale.
That's exactly.
You know, so we don't invest in the capital. We have not invested in the workforce. And so, look, you know, very briefly, what are the things that might give us hope? Because this is a point that Kevin in the chat asked me to expand upon. So if you did a lot more work on prevention, so prevention is actually a really cheap and cost-effective way of tackling some of these issues. The tax on sugar in drinks didn't cost anything at all. It raised some revenue. It let reduce sugar in drinks. It will have made some contribution to reducing diabetes and tooth decay, and didn't even stop people drinking the drinks. It just meant there was less sugar in them. Hopefully, we'll see some quite radical proposals in Javid Khan's review of smoking. I noticed in New Zealand now they've got a policy of raising the smoking, the age you can smoke 1 year every year. So it'll be 18 this year, 19 next year, 20, and you know, within 15 or 20 years, there'll be no one smoking anymore. So there are preventative things we can do. Secondly, going to James' point, there is secondary prevention, which is identifying those people who are most at risk and intervening much earlier to support them, to avoid them ending up in a situation of high-level dependency and bouncing around the health service. We can have an approach. We can think about the expansion of virtual care, hospital at home, because, you know, as Ian said, hospitals are the most expensive and sometimes the most dangerous places to treat people. So let's treat a lot more. Let's move as much as we can of acute care out into other settings and into people's homes. Better integration of services, better collaboration between organizations in the health service. They too can make a significant contribution to this, and a kind of health in every policy approach where we recognize the implications of housing policies, welfare policies, debt policies to health. So if we had what Wanless called a fully engaged approach to health, I genuinely believe we can see our way out of this kind of sense of the hamster wheel, the accelerating hamster wheel we're on, where the only real question for the NHS is demand. And I just finished by saying this: the actual threat to the NHS is about quality and inequality. It's not in the end about demand. We can crack the demand problem, but if it feels as though better off people can't get the quality of care that they want, that they have to wait years for operations and they can pay themselves and get to the front of the queue, and if we don't tackle the fundamental problem of health inequalities and health outcomes, which is an affront to the core values of the NHS, it is quality and inequality that pose the existential threat to our system, not the demand challenge. That can be solved, and we need a bit of hope right now, because actually I think pessimism is one of the biggest threats we face.
Yeah, thank you very much, Matthew, and thank you very much all three, but you're still on stage. But can we now open it out to the wider audience, and those of you who want to put some questions, please put your hands up or wave wildly at the screen, and I will try and introduce. Who would like to go first? Any of those of you who've commented on in the chat show?
There's some great comments in the chat.
There indeed. Here we go to Natalie Bradford. Your point about different outcome measures for treatment of patients and between social and healthcare, is that something worth considering?
Kevin's got his hand up as well, Steve and Mark.
Pardon?
Kevin and Mark have got their hands up.
Yeah, thank you. While you're thinking about that, can we kick off with Kevin? Kevin Langford?
Yep. 1 second. Let me just get myself on the screen. Hang on. Better. Yeah. So I mean, a couple of things in the chat to pick up on. I mean, one is, what can you do to change the power of the centre and the political push for the centre to change, to make things better? Can you change accountability and push that further, push that more locally? Or can you get more of an acceptance that things will be different in different places, and that this is not, that a postcode lottery is not is just how things are, rather than something that a government has to do something about? So that's one theme. And a second is, I'm just interested that there's not enough capital being spent, because generally our fiscal rules set it up to make it quite easy for politicians to spend capital. It's spending, it's revenue spend where all the Treasury has all the constraints. So there's a couple of thoughts and questions.
Thank you, Kevin. Does anybody want to take that one first?
Well, I'll just respond that actually the two parts of Kevin's question are related. Part of the reason for the fact that we don't have enough capital spending is because we centralise the decisions about capital spending. The centre is unbelievably slow, for example, at supporting reconfiguration. And one of the things that Confederation's been working incredibly hard on, the NHS and Care Bill, is trying to avoid the Secretary of State taking even more powers over reconfiguration. One of the good things about COVID was that we were allowed to get on with kind of pragmatic, soft reconfiguration in order to, for example, to develop, hot and cold sites. And actually, I think as we develop develop collaboratives, horizontal collaboratives between different provider trusts, one of the things we need to do is to give them the freedom to do more in the space of reconfiguration, because that could make a substantial contribution to using our workforce and our capital stock better. In relation to the kind of broader issue of central control, I mean, look, I used to work in Downing Street, and I worked for a government that even while I was working for it, I felt was over centralising. It is simply the fact that when you're at the centre, you're under incredible pressure, and you tend to believe that pulling levers and setting targets is the way of pacifying the public and making a difference. And unfortunately, it really isn't. And it takes a lot of deep thought and cultural change for institutions at the centre to understand this. And I think one of the advantages of ICSs is that actually I think that although local government is very patchy, and of course it's very patchy, but actually local government has done remarkably well over the last 10 years. It's been absolutely starved of resources. It's had to change the way it works. It's actually been very entrepreneurial in terms of identifying new income streams, being, working in different kinds of ways to keep itself afloat. And of course, it has to balance the books every year, unlike NHS institutions. But local government, in the end, has some freedom. One can say to the Secretary of State at the Department of Levelling Up, well, you might want to do that, Secretary of State, but you can't, because these are local authorities and they have their own democratic mandate. One of the things I think is interesting about ICSs is that integrated care partnerships are genuine partnership bodies. And actually, whether it's DHSE or NHSE, cannot tell them ultimately what to do, or if they do, it will be counterproductive. Because why should a local authority work with health partners who say, well, we have no latitude for local decision making, we can only implement what is told to us by the centre? So I'm hoping that the creation of ICSs and ICPs and place-based bodies will create a more pluralistic feel in the health service, and will enable the health service at the local level to be able sometimes to just say no. You know, we understand what you're trying to do and we accept public accountability, but that is simply not something that we can deliver, because we need to be able to push back sometimes. Otherwise, you know, otherwise we'll never get off that hamster wheel.
Mark, would you like to make your comment?
Yes, thank you. Look, I think everyone agrees about the imperative to invest and the benefits in terms of long-term gain, either through better health or by reducing later costs. I suppose the trouble is that the person making the investment is not necessarily the person getting the return. And that creates an incentive problem or a maturity mismatch problem, where we're asking one person to pay for someone else to benefit. And that just seems to me to be a recipe for paralysis. How do we fix that? How do we change the game so that somebody who makes an investment in prevention sees the benefit and is therefore incentivized to make it? The example I might give, so I lost 10 stone in the last couple of years. I'm sure I've made a huge difference to my chance of type 2 diabetes. I'm sure I've saved the NHS tens of thousands of pounds. I did it off my own bat. But if local authorities were incentivized by saying, we'll give you 50% of the saving you make by preventing these things through investing in social care, well, then they'd spend the money. And I just think, is this an incentives problem, or a connection of the parties paying and the parties receiving, so that we can work at the pace of the innovators, not at the pace of the Treasury, the slowest moving part of the economy?
Ian, would you like to take that one first?
Yeah, I mean, I think that would be a solution. I think if the ICSs were given longer term objectives, so that we reduce diabetes, for instance, which we know is a hugely expensive disease, and we're given the time to do it. I think that is the problem that Matthew talks about. Partly it's about data, you know, and I think we've got to do a much better job at proving these things. Anybody who's been in business will know that if you invest in a diabetes program in the short term, that's actual cash out. The benefits are 5 years down the road, and who the hell knows how you're going to get those. So, you know, it's a really tough management challenge, but I think competent managers have to rise to that challenge and really show that there is a payback to the taxpayers and to the individuals who are, you know, living better lives as a result of it. I think the other problem is short-termism, and I understand Matthew's point. The politicians want immediate answers. It's headlines in the Daily Mail which they respond to, and I'm sympathetic to that. And as I said earlier, I think we have got to try to help them deliver that. But I think we've also got to say, if I'm really going to take investment out of the hospitals, activity and patients out of hospitals, and put them in the community more safely, integrating social care with healthcare and supporting carers better, and the third sector and charities and so on, then give me a couple of years to do that, because there's no way you can do it overnight.
Thank you, Jane. Jane, what's your view? And would you like to broaden into the mental health issues, which we've alluded to, but rather tangentially at the moment, but of course, which is such a huge problem in their own right?
Well, first of all, Mark, many congratulations. That's an awesome, impressive achievement. And I'm interested in this idea of investment, actually, and who it is that's investing. I mean, I see it as me as a citizen investing in our collective future, and maybe not enough people see it that way. And actually, I'm investing in the NHS by paying my taxes, even though I don't draw very heavily on it at the moment. But I never know when I might need to. And I think we need that sort of thinking about social care, and some of the messages, like what happens to one of us happens to all of us, because, you know, many people have now got relatives that need care and support, and they're having to give up their jobs to support them. So that does affect you, you know, and I think some of the countries in the world where they've recognized this, you know, that they've recognized that sort of wealth and health are intimately entwined, and, you know, the greater the inequalities in one, the greater the inequalities in others, and the societies that are the happiest have got the smallest gap in those inequalities. And so that trying to get the idea that we're all investing in our own future I understand why the politicians put money in the NHS, because it's just a political, everybody understands the NHS, it's a tangible thing, they think they understand anyway. And the public gets very upset if there's any suggestion that it's not going to be invested in, but don't necessarily understand what social care even is, and how it sort of interfaces with it. So that's why I think the integrated care systems are going to be a good thing for social care. And especially to Natalie's point, you know, if we can come up with some outcome measures that integrate all of it, you know, it's not just your blood pressure, it's, you know, how mobile are you, how connected are you with your family, you know, how many drugs are you on, you know, how much time have you spent in hospital. I'm sure that there's a whole load of things that we could collectively come up with, and I'd like to see the integrated care systems being measured on those sort of outcomes. And ultimately, I think, you know, there's a government document somewhere that says we want to increase healthy life expectancy by 5 years. Well, that would be good, but, you know, how do you come back from that to something on the ground that's meaningful?
Thank you. Julian, you've got a question.
Great, thank you. And really, really interesting, fascinating discussion. I just wanted to pick up on some of the politics of this. Matthew's alluded a little bit to it. The health and care levy was really interesting because it essentially dealt with one aspect around social care, that of relatively rich people and protecting essentially inheritances. When you poll this, you find that health and care levy that's framed as protecting inheritances actually polls better than a health and care levy that's framed as guaranteeing more funds to the health and care system. As in, the politics drove the government. It wasn't random that that's where the money went. I'm just interested in what people think the resonance of this entire debate could be with the public. So what are the issues here that actually get people to think, right, that's something we want to sort? When we've done some deliberative work, the only frame around social care that we could test in that really worked was around the workforce. And how did you recruit, retain, train a workforce in social care? Everything else about social care, supporting independent living, helping us in our frail old age, things like that, people nodded along to, they didn't disagree with it, but they never returned to those issues later in the deliberation. So I'm just wondering, are there ways to get the public thinking this is a really important issue that resonate with them at the moment, that you could build a political platform around?
Matthew, do you want to reply to that?
Yeah, well, it's great to see you, Julian. Look, I don't think politics should ever just be about responding to what the public think, because what the public think when you ask them what they think in an opinion poll is very different from what they think when they've been discussing something in a deliberative forum for several hours, or you know, what their priorities is very different when you set that priority against other priorities. And, you know, the role of politics is also educational, developmental. And, you know, this is why I think that right now what we need is a political case to be made, which says, do we want to spend forever with a health and care system that lurches from crisis to crisis? Or do we want to make the investment and to get the right policy framework to take advantage of data, of digital, of med tech, to get to a more sustainable position? And it is really possible to do that. And I think that argument had been half won, and then it was lost. Austerity, I'm not making a political point, it was a different time, but we need to make it again, because in the end, the way we're working is not only, as I said at the beginning, ethically wrong, but it's ultimately counterproductive. It leads to huge amounts of what John said calls failure demand. You know, that a lot of what is consumed in the health and care system is consumed because we didn't get it right first time, unfortunately, and we didn't direct people to the right services in the right way, and we're not investing in the right kind of innovations that can make a difference. So I think that's the case we have to make, Julian. And I think maybe on the back of COVID and on the back of the sense of crisis right now, a political message that says there is reason to hope that this is what we have to do in order to get to that better place. Maybe that is a message that can resonate, but it's not. The point about a political message like that is you have to hammer it home for years. You can't just do it overnight. You've got to start making that case. You've got to mobilize people, and you've got to build it. But that's what I think we need right now.
Thank you, Matthew. Barry, we're very hard up against time. Do you have a relatively short point you could make?
Yes, I'll try and make it short, even though it is deep. And that is the issue of mental health, which of course crosses over. And we all know it's threadbare. It's absolutely threadbare. I don't know a place in the country where it isn't. So that's the general question about this. And the provocation is this, that perhaps the most egregious externality of our economy, now that we've identified carbon and all the rest of it, is stress. And we've had the sugar tax, and Matthew has talked a little bit just now about that was a success in its own terms, certainly. But what if we were measuring stress efficiency, i.e. lack of it, in companies and the way companies operate, in the same way we measure energy efficiency and taxing accordingly. As I say this is a provocation, but my question really is, where does mental health fit in with all this, and how should we join those dots, or do more than that, really?
Thank you very much, Barry. It's a very important point. We've got to the end of our time, so I'd like to go back and perhaps incorporate your mental health point. Also, I think others have made the point about education, general education on health and so on. But these are crucially important points, and thank you everybody for your contributions. But could we finish by going back to our three panelists and starting with yourself, Ian, with a short summary?
I think we've got a lot of work to do. I think the ICSs are the right route forward. I think we have got to make the case, frankly. I think we've got to be held accountable to our local population to deliver better health outcomes. To your point, Barry, we're increasingly discovering that health and physical health are completely integrated. And, if you have diabetes, you have mental health condition, and you really have to treat both of them, frankly, if you are going to get a patient to be better. And I think we've got to find, I think it's a responsibility of us in the ICSs to communicate and talk to our citizens and patients. There's such trust in doctors and nurses and, social workers who interact with their patients and citizens. We've got to give them the tools, I think, to communicate this face-to-face, which is the only way it'll happen. Thank you, Ian. Jane?
Thank you. I think, maybe the same argument to the public that was used originally for the NHS, it's a kind of insurance thing. We never know when we're going to need it, but we're all only ever one accident away from needing that sort of support. And none of us psychologically can project ourselves forward. None of us can imagine ourselves older and iller, so in a way it's about pooling that risk, I think. And I feel quite optimistic that if we really keep going with the ICSs, and it's all about relationships, it honestly is. It's about getting people to work together towards a common purpose. And that's why I get bored with the conversations about organisation, because I just think it distracts us from what we actually really need to do, which is focus on people needing support. So,
thanks very much, Jane. Matthew, how would you like to close?
Yeah, 2 points. First of all, on mental health, I think there's an opportunity for ICSs to develop mental health strategies that are not just about the health service, but are genuinely holistic, thinking about all the things which are shaping mental health outcomes, including, to Barry's point. And what I worked on before I came into health was work and the concept of good work. So I don't need any persuading of that. And indeed, I would end up with this plea. We have a workforce crisis in the NHS, and a big part of that crisis is because of the jobs we're asking people to do. And we're asking health workers to do impossible work. We're asking them to work in a way which does not live up to the ethical standards which made them come into the health service. And so if there's no other reason for us to try to get reform right and investment right, is to make sure that our health workers are doing the job. There's nothing more heartbreaking than for an ambulance, someone who's working the ambulance service, to know that had they been able to arrive a few minutes earlier, they could have made an enormous difference to someone, but they didn't because they arrived late. We are seeing now the majority of GPs do not want to work full time, and I think that's often to do with the intensity and stress of their work. So actually, when we think about workforce, if we gave ourselves the goal of ensuring that all health and care workers had jobs that were truly fulfilling and enabled them to fulfill their sense of purpose, we'd be a long way actually towards having the system we want.
Yeah, thank you very much, Matthew. And can I thank everybody for their contribution this this evening. This is an immensely large problem, but I do get the feeling that there is a beginning of a view of some form of consensus, which does hold hope for the future.